Thank you, Dr. Gulati. Well, this is really, I don't treat kidney cancer patients, but I'm surprised, and I mean, it's good for patients that they have so many options, but I can't imagine being an oncologist who treats renal cell carcinoma at this point, and to select from all these treatment options. So
Right.
with that,
You put Dr. Choueiri on speed dial and ask him about
that's probably that's probably the best option. Should be option number one for renal cell carcinoma. Yeah. So I will encourage people to type in the questions for Dr. Choueiri, Dr. Gulati, and rest of the panel for this session. In the meantime, we'll go into the Kahoot platform for doing the some of the questions that Dr. Gulati and Dr. Choueiri have for us.
Vidhi, would you like to explain everybody?
Yeah, sure. Let me get started on that. Okay. Hi again, everyone. I'm Vidhi. I'm one of the interns. So one of the ongoing projects at the Binaytara Foundation is finding ways to make our conferences more engaging, interactive, and effective at teaching the lecture content. And one way we're addressing that is through gamification, which is the application of game design elements such as leaderboard, timed challenges, a scoring system in a non-game like setting such as this conference. And today we're going to use Kahoot, which is a game-based learning platform, to answer 4 questions that have been written by Dr. Gulati and Dr. Choueiri. So 2 questions from each of them, very similar to before. So to get started with that, if everyone could either pick up their phone or just grab a tablet, and you're going to want to go to this website right up here called kahoot.it. And then once you get there, I will screen share with you guys a pin to enter the game so we can start answering questions. And after you enter the pin number, it's going to ask you for a nickname. You're welcome to choose your own name, abbreviations. In the past, we've had participants choose like fictional character names. So whatever you'd like to use, it's up to you. And most importantly, yeah, I'd encourage all of you to participate in this. It really helps us figure out if this is a good way to continue using gamification. And yeah, at the end of the conference, we'd also just love your feedback on this. All right, so here is the pin number that you're gonna wanna choose. So once you get to the website, kahoot.it, it's also right up here, you're gonna wanna add that, and then we'll be able to get started with the game.
I love the name RCC.
And Dr. Gulati and Dr. Choueiri, similar to before, feel free to jump in with further explanations as we finish answering your questions. I'll just give you guys one more minute and then we'll go ahead and get started with the game. It's also going to be open. So if you feel like jumping in as we start answering questions, you're also welcome to do that. But yeah, thank you everyone for participating. And just a quick heads up, if your phone screen locks or anything, it looks like you've been kicked off of the game, but the moment you unlock it, you will be back in. So don't worry about that. All right, just to keep it going, I'm gonna start the game, and then if you still like to play, the code will be displayed at the bottom as well as the website. So the first 2 questions are based on Dr. Choueiri's presentation.
Sid, would you like to read the question?
Yeah. So 59-year-old man, previous smoker, mild hypertension, presented with 2 days of gross hematuria, intermittent fevers, and 10-pound weight loss for 3 months. performance status of 1. CT urogram shows a 9 centimeter renal mass, and CBC, CMP, LDH are all normal except for a hemoglobin of 11.1. So patient has further staging with CT chest, abdomen, and pelvis, and MRI brain. And this shows 10 to 12 pulmonary nodules, the largest one measuring 2.2 centimeter. He was immediately taken for a cytoreactive nephrectomy showing a clear cell renal cell carcinoma plus 80% sarcomatoid differentiation. So I guess the question is, what is the best treatment in this case? What are the next best steps? Okay. So Dr. Choueiri, do you want to comment on the case and your treatment
Yeah,
choices?
so, patient sarcomatoid histology, sarcomatoid RC, it's not its own entity. This is a dedifferentiation, tumoral dedifferentiation that can exist in any histology, clear cell or non-clear cell. It's similar much to rhabdoid differentiation. We group them both together. And it's been a vexing problem because single agent VEGF TKI as well as the mTOR inhibitor have not yielded much result. We had some data with cytotoxic chemotherapy. Initially was quite promising, but later on, when more result came in, you have some responses in some patients, most of them non-durable. Then when immune checkpoint inhibitor came, we've seen responses to them. And no matter how you look at each clinical trial that has a IOIO or VEGF-IO, you see the hazard ratio for OS, for PFS being better than even the general population. Considerably, nivolumab and ipilimumab have been the subject of this recent publication with Nizar, Sabina, Brian, and many else, show the CR up to 19%. So this is real. And why this is real is that because the underlying biology of sarcomatoid RCC suggests a potential response to immune checkpoint inhibitor. They have high rate of PD-L1 by IHC amplification. They have signature that favor an immune response in a way, as well as very much adverse prognostic signature that maybe could be overcome by immune checkpoint inhibitor. We don't see much angiogenic signatures. So all this could explain why immune checkpoint inhibitor and about nivo-ipi compared to others, simply because this is the highest rate of CR and the more mature data. So this is a situation where patients that have sarcomatoid and rhabdoid dedifferentiation, even if they progress on immune checkpoint inhibitor not called nivo-ipi, I then re-challenge them with the combination of nivo-ipi.
Gotcha. Perfect. Thank you. Okay, next question. All of the following are correct except, so 72-year-old woman comes to see you for a second opinion regarding her metastatic clear cell renal cell carcinoma, presented 6 weeks ago with painless hematuria that led to discovery of a left large kidney mass and several pulmonary mediastinal lymphadenopathy and 2 liver lesions. Biopsy of one of the liver lesions showed clear cell renal cell carcinoma. Performance status is 0 and the hematuria subsided. She was told she can take a pill that could make her tumor shrink. She's asking about a therapy that can extend her survival. All of the following are correct except, so I guess the question is, which of the following do not extend survival? Okay. So this one is, I guess, fairly straightforward. Dr. Choueiri, do you have any other additional comments on this?
Yeah, no, I wanted, you still see a lot of TKI frontline. There is no room for TKI frontline. We can think about patient with IMDC favorable risk. We're also trying to dissect that subgroup and divide it based on the IMDC database into even 2 subgroup, the favorable risk, but less and less, the use of VEGF TKI frontline. Now, of course, I practice in the United States, in the East Coast, so I think the rest of the world is like the East Coast, even in terms of weather. So I'm looking outside here at the snow, and it's 2 degrees, 2 Fahrenheit in Boston. But we need to remember that, any systemic therapy that is available. So if we're in the cancer center of Nepal and what's available, it's VEGF TKI only. I do have patients with poor, intermediate, and good risk who have long-term outcomes from single agent VEGF TKI. So keep in context all that.
Great, thank you so much, Dr. Choueiri. And now we're going to answer 2 questions from Dr. Gulati.
Okay, rank these in the order you would choose first to last. So 64-year-old female patient presents with 2 months of fatigue, back pain, and unintentional weight loss. Only significant past medical history is hypertension. Exam shows tenderness in lower spine on palpation, and CT abdomen pelvis demonstrates 8.2 centimeter mass on the right kidney and some para-aortic lymph nodes. Biopsy confirms clear cell renal cell carcinoma, underwent a right total nephrectomy and was on surveillance. 2 years later, she developed stage 4 disease with lung metastasis. Labs are normal, ECOG 0, started on oxypembro, and 2 years later has progression of lung nodules. What would you choose next? So you have somebody who has metastatic RCC, progressed on oxypembro. What are your sort of, so you've got to rank these in the orders you would choose first. Okay, so Dr. Gulati, do you want to comment on this?
Yes, I think the 5th option, I don't know, there was probably not enough space to have a 5th option, but the 5th option was, either one is a reasonable option. Like patients who progress on an IO-TKI based combination, like I showed you, there is some data to support use of dual checkpoint inhibitor. You might want to use the lenvatinib, everolimus, but that, and then cabozantinib is also an option. So we really need more data, more prospective data to sort of sequence these agents in the setting.
Sure. Okay, next question. All right, so true or false? 75-year-old male presents with back pain and weight loss. CT scan demonstrates 8 centimeter renal mass and lung metastasis. Received pazopanib 4 to 5 years ago. Now he has progressive disease. He has poor performance status, and you decide to start him on single agent nivolumab. He has partial response. Can we give nivolumab monotherapy first and then salvage IPI? Okay, Dr. Gulati, do you want to comment on this?
Yeah, so like I pointed out to, we do have 3 clinical trials recently presented, and the approach to adding salvage ipilimumab if somebody has not had a good response to nivolumab is not a currently recommended option.
Okay, I think with that, we go back to our Zoom session. And so we have a question in chat, which I think is a little kind of interesting question in terms of timing of response. So let's say if somebody has metastatic disease and we are looking for a more robust response, does that ever change your treatment decision in terms of what you select as first line treatment in advanced RCC? So whether you would choose IO-IO or IO-TKI combination if you're looking for a more robust response. And I guess I'll go to Dr. Choueiri first on that one, and then anybody in the panel could answer as well.
have to repeat the question for me, I think. So if you have the question is, if you have a very good response, could you stop or,
So,
you
the
know,
question is more like if you have a very high tumor burden and you're looking for a more robust response, does that change your, because does IO take more longer to work, or IO TKI might be faster option to work? Does that change your treatment selection decision at all?
I think when you have, and this remains very still subjective, when you have a lot of tumor burden, in patients, so consider liver metastases, multiple organ, impending cord compression, a lot of bone mets where you don't know when someone gonna start having pain and potentially cord compression. You want to go with any regimen that has the highest response rate, knowing that even highest response rate. And I would say I would challenge here the dogma by saying really it should not be the highest response rate. It should be the lowest rate of PD as best response. And with VEGF-IO, we are seeing PD as best response rate go down to less than 10%. We're seeing it in the 5% range with some of the VEGF-IO regimens. So this is an indication where I would start with a VEGF, IORIA, regimen, the one that have the lowest, PD rate. So Cabo-Nivo, for example, combination, I believe the PD rate, I should know that data right on top of my head, but Binay will tell you there's so much data that sometimes you doubt yourself. Where did you read here, there, what table, etc. And you have the, the information on top of your fingers. So I think the Cabo-Nivo was like 5 or 7% PD as best response. So, exciting times in renal cell.
Any other thoughts from the panel members? Okay, we go to the next question then. If somebody has CNS metastasis, how would that impact your selection of first-line therapy? Dr. Fan, Dr. Gulati, anybody?
Well, the hard part is a lot of the clinical trials exclude brain mets, right, as inclusion criteria. So, so it's hard to extrapolate, although there were some trials that allowed previously treated brain mets. And so the key thing first is get control of the brain met, take care of that. And then, Ipi-Nivo does actually cross blood-brain barrier, as do some of the TKIs. So you just have to be concerned about TKIs and risk of bleeding. But you can actually treat them with checkpoint inhibitors and or TKIs carefully.
Dr. Desai, Dr. Choueiri, or Dr. Gulati, any additional comments on that? Would you do anything differently in this situation?
No, I completely agree with Dr. Fan. The biggest dilemma is that, these patients were excluded from clinical trials. But yeah, I mean, first priority is to take care of the brain mets, depending on the number, location, and all that. You want to get that situation sorted out first, and then either an IO combination, or there's no clinical trial data, but our carefully chosen TKI IO combination is fine too.
Yeah, I think said very important. Take care of the brain first, but I want to question about some of the IOUs. This is a bit different than melanoma data that we've seen with Hussein Taubi with Nivo-Ipi, patient with brain metastases responding. First, in the US, we have the luxury to have radiation oncologist, surgeon, always on call. We just page them, they take it out. But the French actually taught us the most. The French taught us a lot beside food, cheese, and wine, but they taught us a lot about renal cell. And one of my early mentors was Dr. Bukowski, was Dr. Escudier in France. We worked many years ago when I was much younger on one of the clinical trials. Now, listen to this, used shark cartilage in renal cell, a trial against shark cartilage versus placebo. Imagine that trial passing the IRB now. Of course, the hazard ratio was 1.0. So one of the things beside the Carmina trial, cytoreductive nephrectomy, the French taught us is using systemic therapy in patients with untreated brain metastases. So there was initial trial with VEGF-TKI from Stefan Udar at Pompidou, that patient with sunitinib. Now we can say crossing the blood-brain barrier. Nobody understands really the blood-brain barrier, because the blood-brain barrier in patient with bone metastases is probably violated. And we don't know how the effect these are. So initial case report of tumor shrinking on sunitinib. So that led to a randomized to a prospective study conducted by Sylvie Négrier, also in France, that actually showed that TKIs in untreated brain metastases simply do not work. Then the IO came, and of course we copied the melanoma literature a bit and start doing these trials. And Dr. Albiges and Flippo from France just published in JCO not long time ago their experience with single agent nivolumab in patients with brain metastases. And the experience was terrible. There was no much responses in untreated brain metastases. There were some hint of response in very small tumors. Now, there will be data with at GU ASCO. I want you to be tuned for. It's still, the data is embargoed, and I don't want to get in trouble, about some retrospective data coming with, another TKI, and what therapies could be, again, retrospective. But Dr. Négrier is conducting a prospective study called Cabramet with cabozantinib in patients with untreated brain metastases. The other thing I want to answer is brain metastasis is fine. We can control them sometimes. Sometimes when we can't, we still don't know what to do. But the vexing problem is, and it's not common though in renal cell cancer, but we're seeing it now that we have so many therapies, is leptomeningeal disease. I don't see that much in RCC, but you see it from time to time. That's a problem. That's a problem not to have a response, but also it's a problem because how would you evaluate the response if there are, responders or not? So hopefully we don't see that.
Thank you. So next question we have is kind of similar to the earlier one, is basically in a 45-year-old woman with painful bone mets, metastatic clear cell renal cell carcinoma and VHL mutation, if you did radiation to a couple of bony sites, and that was the only disease that was there, and you took care of that, and there is no more measurable disease, how would you think in terms of systemic therapy? Would you go ahead and treat this patient, just observe, or what treatment options would you use? I guess I'll go to Dr. Desai on this one first.
Yeah, so if the only sites of disease have been radiated, the patient is doing well symptomatically, has good risk disease, then it's reasonable to monitor with serial scans closely. We don't have to start systemic therapy. Obviously, if it depends on the patient's clinical status, if they have a lot of systemic symptoms, not doing well, then it's reasonable to initiate systemic therapy. But again, if they have just oligometastatic disease, and the sites of disease have been treated definitively, then it's reasonable to just monitor and not start systemic therapy.
Any other thoughts from the panel members?
I think that's very, very, very good answer, very smart answer. I see a lot of patients that, sometimes, stopping, continuing, keeping the patient. This is not small cell, despite very aggressive kidney cancer can be, where you're going to immediately see patient progressing. It's not, we see it, but it's not common. So it's fine, especially if you use immune checkpoint inhibitor, you control the disease. Think about it, about giving a patient a bit of time off or drug holiday. There is no evidence here that you're going to impact the outcome. The one thing that we don't want to happen is these patients that has been, let's say, on immune checkpoint inhibitor nivo-ipi had an immune-related AE, but also had a response. Someone immediately starting steroid and giving them prescription for their favorite TKI. And I'm like, wait a second, there are patients that have discontinued therapies and did not need therapy, or then the tumor progressed after several months or years. Why not giving them, the time off?
And I think if I read the question, this patient also has VHL disease. So is this, if we're talking about a patient with a germline VHL, they're going to be in this for the long run. In general, their VHL tumors can be a little more indolent. And this is a patient that's going to develop more tumors over time. So you don't want to give them a lot of toxicity with no clear benefit. So we definitely want to be thoughtful about that for this patient.
Great. Okay, so with that, I think we will conclude the session today. I really want to thank all of you for joining us today.